Hello and welcome. I'm Dr. Alex Spyropoulos.
And I'm Dr. David Rosenberg.
And we'd like to welcome the DVT support group headed by Dr. Joe Caprini as part of what we'd like to call the other North Shore Health System in Chicago, Illinois. We can't tell you how wonderful it is that we had Dr. Caprini here in a very important anticoagulant related session in our system about a month ago. And we'd like to share some of the experiences of anticoagulant care, specifically on venous thromboembolic disease, or VTE, that we've started here at Northwell Health Systems. Now, my position, I'm a professor of medicine at the Hofstra Northwell School of Medicine. I'm also a Feinstein investigator here at the Feinstein Institute for Medical Research, and I'm system director for anticoagulation and clinical thrombosis services. And together with Dr. Rosenberg, we're co-chairs of a very large initiative called the Clot Initiative with respect to standardizing and modifying and importantly, bringing high levels of anticoagulant-related care to our health system here at Northwell.
To share a little bit about myself, I'd actually want to start a little bit about our partnership between myself and Dr. Spyropoulos. We really have a wonderful partnership. Dr. Spyropoulos is truly the national and international expert, having published hundreds of papers on anticoagulation and thrombosis-related issues. And then my piece of this is that I'm really the implementation guy, and we have to figure out how to take all that research and guidelines and make it real and put it into our electronic medical record and really deliver it to our patients so it really protects our patients and make sure that we give the best care that we can to our patients here at Northwell Health. My position is that I'm the Director of Evidence-Based Clinical Practice, and this type of work really fits into that title in clinical transformation. I'm trained in internal medicine. I'm a hospitalist, care only in the hospital setting with no office practice, but I've learned to have a wider view around the anticoagulation and thrombosis issues for both inpatient practice as well as for outpatient practice.
And what we know is that venous thromboembolism, or VTE, is really a global health problem, both here in the United States and also abroad. And after patients with cardiac disease and stroke as an illness, VTE represents the third most leading cause for both morbidity and mortality of patients worldwide with cardiovascular disease. But at the same time, what we've realized is that the hospital is a major source of VTE in the community. And indeed, hospital-related VTE now remains the #1 cause of a VTE in the community environment, especially within 90 days of hospital discharge. But even putting all that together, what we see is an extremely low public awareness on VTE. Indeed, an interesting and very recently published survey by the International Society of Thrombosis and Hemostasis as part of global VTE awareness showed that at a public opinion level, there was a low level of understanding both with respect to the signs and symptoms of VTE, but also importantly of the risk factors for VTE, such as cancer, such as recent hospitalization, or a recent major surgery. So to put this all in perspective, what we're trying to do here at Northwell is both at the health system level, but also at the patient level, which is why your input is so valuable as part of your DVT support group, is to increase awareness of VTE as a public health problem here at Northwell Health. And maybe, David, you can share with us some of the more innovative things that we've done within the Clot Council initiative here at Northwell Health.
So yeah, I'd be happy to do that. The Clot Council is a large group. We're a large health system. We have 21 hospitals, and the work that we do, we try to spread across our entire organization so that we have a standard way of approaching various disease states, and that includes patients who need to be on an anticoagulant. And we've been able to leverage that by bringing people together from across the health system. And our Clot Council has more than 140 members from across the health system, interdisciplinary group, physicians, pharmacists, nursing, blood bank. It's really an amazing experience to be able to work with all these dedicated professionals to put together the best way of caring for patients with a thrombosis, or even equally or more important would be to prevent blood clots. One of the things that we've done over the last several years is to try to keep up with the guidelines in thrombosis and anticoagulation. And those guidelines come out every few years and they change how we should approach patients. And we can reach back as far as 2012 for the guidelines from the American College of Chest Physicians, which is really the gold standard for guidelines on this area in the United States. And they really changed how we think about preventing blood clots. The process in the hospital setting. The process used to be based on what type of patient you were. You were a medical patient, you were a surgical patient, you were having X procedure or Y procedure, and that would say, this is the type of VTE prevention, these are the type of medication or maybe no medication you should receive. Well, it turns out that that doesn't work optimally, and we know that we are probably giving prophylaxis or medications to prevent blood clots to the wrong groups of patients. And we're probably, for the patients who need it most, we're probably giving it for too brief a period of time. One of the things that's changed in the hospital setting, when the studies were done 10, 15, 20 years ago that tell us that we can prevent blood clots with using medication, the patients stayed in the hospital for long periods of time, and they got 10 to 14 days of a medication to prevent the blood clots. Today's world, we get patients out of the hospital in 4 days, 5 days maximum for most conditions. And that prophylaxis, that medication is only being given while they're in the hospital, and we're not completing that primary course. And so there's a lot of work that needs to be done to make sure that we're giving that prophylaxis to the right patients and for the right duration. And one of the ways that we're working to ensure that we can do that is to look at the individual patient risks, not what group you belong to, but who you are as an individual. What is it about you that says that you're a low-risk patient, we don't have to worry about you, and we should not give you any medication, because then all we're offering you is potential side effect and no benefit. And what would make you a high-risk patient, and therefore the benefits of the medication would outweigh any risks, and then you should have it. And then we have to figure out how long you should have it for. So one of the innovative things that we've done in our health system is to validate several risk assessment models to determine who is, number one, at risk for a VTE event, who is at risk for having a blood clot, and who is at risk for bleeding. And we've taken two models that come from the IMPROVE study, which is a large international study that determined the risks for both having a blood clot during your hospitalization or from your hospitalization, and what's your risk of having a bleed. Two separate risk models were determined from that large study of about 15,000 patients that Dr. Spyropoulos was a key person involved in that study. And we validated it in our own population here at Northwell to say that that risk assessment tool, both of those tools actually work really well in our population, and they really give us guidance as to who are the high-risk patients, who we need to pay attention to, who need to receive the right prevention, the right prophylaxis, and who are the low-risk patients that we need to prevent them from receiving a medication because they really don't need it. And it's work like that that we're really interested in rolling out across our health system. And also, it's really important that we share this with you as patients who have had blood clots, because public awareness is critically important for this problem. One of the obstacles that we face in the hospital setting is that we talk to our patients and we say, we want to prevent you from having a blood clot. And a lot of people are like, well, I don't think I'm at risk. I don't need that. Whether it's a medication or whether it's a device we put on the legs, it's a compression device to prevent the blood from collecting in the legs, and a gentle squeeze pushes it out. And especially with those devices, people don't like them because it slows them down. It's harder to walk, or they can't walk, and they get taken off. They don't get put back on. And we really need to turn that around and do it differently. It's important for us to provide education even before you're in the hospital. If you're going to have surgery, you need to be educated. You need to know that surgery is going to put you at risk, And what you can do as a patient is know that you're at risk, and when you get into the hospital, make sure you're getting what you need. You do, unfortunately, care in the hospital is very complex, and the better people can advocate for the care that they need, I think the better the patients will do across their hospitalization. And one of the things it would be great to advocate for is to make sure that you're receiving the right and the best medication or a mechanical device to prevent a blood clot from occurring.
I mean, that's a good point. And what you're saying is we've really gone away from the era of what we call group-specific prophylaxis. And in the last few years, we're starting to develop and validate an individualized approach to VTE prevention, especially in the hospital. And as you all should be aware, at your facility, Dr. Caprini has been the author of the Caprini score in surgical patients, which is probably the most validated risk score in that group of patients. And as David said, we're actually working with the improved risk assessment tool here at Northwell. But then it puts the onus not just on the physician, but also on the patient to understand their individual VTE risk factors. And as you stated eloquently, you have to know your own VTE risk score. And it's up to you to talk to your doctor and say, Doc, what is my VTE risk score, whether it's for a surgical procedure or a hospitalization for an acute medical illness. And it's also important for your family to be advocates in this whole process. Because what we're realizing more and more is that we're probably over-prophylaxing many patients with pharmacologic agents that puts them at risk for bleeding, and likely, as you said before, under-prophylaxing a small group of patients that may be at high risk for developing VTE and probably need an extended or out-of-hospital duration. So I think that's kind of exciting work that we're doing here at Northwell.
Yeah, I think it's great. I think it really brings together the science of how to do things, what do the research studies tell us to do, and then how do we really put that into operation for our patients, and how do we make sure that our patients are part of the process so that you have the understanding of its importance in your care, and then it allows you to advocate for what you need as a patient. And it's also important for many of you in the group, I would imagine that, and I would hope for you, that your need for anticoagulation might not be a lifelong thing. Maybe you're on it for a period of time, and somewhere down the line, you're not going to be on full dose anticoagulation, and you might end up in a hospital 10 years from now, 15 years from now. Let's hope not, but maybe you will. And knowing that you had a blood clot in the past, knowing that that puts you at risk will help you advocate to make sure that you are given the best medication or the best mechanical devices to prevent that from occurring, prevent another blood clot from happening to you somewhere in the future.
And I think the key, what you said, is truly at the hospital level, a multidisciplinary approach involving all aspects of healthcare personnel, including the physicians, the surgeons, the pharmacists, but importantly also the patient being their own advocate and patient's family members being their own advocates. So indeed, I think as a patient, you should think of yourself as part of the healthcare team, especially now when we're moving to a new era of individualized VTE risk assessment that we're, I think, doing very exciting work here at Northwell. So again, we'd like to thank you for this opportunity to discuss some of our efforts here. I'd like to thank also Dr. Caprini, again, for letting us talk to you in this venue. And we wish you well in the future in terms of your future endeavors with your DVT support group. And again, we would like to thank the other members of our Multidisciplinary Clot Council for their efforts as well here at Northwell. And together, I think we can really make a big dent with respect to both public awareness, patient advocacy, and ultimately a reduction in this very serious disease, venous thromboembolism. I don't know if you'd like to say anything else.
I think you summed it up really nicely, and bringing all those pieces together really is important to us. We thank you for sharing Dr. Caprini with us when he came to visit, and we hope that you found this discussion with Dr. Spyropoulos and I helpful to you as you go through your journey with venous thromboembolism. Best of luck to you. Thank you.
Thank you.